Okay.
So, so thank you, Heather. Thank you for agreeing to allow me to record this for yourself and for this, my students. Who are, also some of which are themselves Nightingale dementia consultants, and so they're not my students, still my colleagues. So anyway, everybody's my colleague, because that is what I've created, is a Lighthouse Brain Health Associates, and I did that with Beryl Coma. And what we're trying to do is to help as many hypnotherapists, hypnotists as possible, to understand that we can have an influence. We can help the caregiver and people living with dementia. So that is what we can do. And Heather, I know you've done your training with Teepa Snow, who I've followed for quite a few years now. And so tell me more. How did you get involved with this? This thing.
Well, I've been an occupational therapist for 25 years,
Mm-hmm.
and my focus of providing occupational therapies, but always been with older adults, some into the adult population as well. And it's really, Teepa is also an occupational therapist, which I didn't even know of her until recently.
Mm-hmm.
But really what happened was, through my practice as an OT, I've just seen so many more people in my facilities and I work in a skilled nursing facility doing short-term rehab. And it just seems over the years, I've seen more and more people coming through our rehab who have dementia, or they are undiagnosed but show a lot of cognitive decline and symptoms of dementia. And it seems to be really complicating the rehabilitation process, in the sense that I think once upon a time we were getting a lot of people who were um, with higher cognitive abilities, but now those people are generally going directly home. And so the people that are coming into a rehab setting are the people that are not presenting as well when they're trying to be discharged from an acute care. So it was with the rise of seeing people with dementia, the training that I already have as an OT, that gave me a lot of insight. I mean, we look at, a whole body approach, whole person approach with occupational therapy. We're looking at, physically how a person's performing. We're looking, how do we adapt and modify what they're doing day to day? Is it that we need to change how someone's doing something to succeed again? Do we need to change the environment to help them succeed again? Do we need to introduce tools, other strategies? So in some ways we're rehabbing the patient, and in some ways we're trying to make the world fit for them. And this just is such a, how do I say, it intertwines perfectly with occupational therapy, when I then also started to think about dementia care. And when I saw so many people, I had a lot of positive interactions with caregivers, just with my limited OT knowledge about how to provide, better care. It really set a spark in me that thought, there's got to be something more that I can do. I really feel like these people need to benefit more from what I can do in a rehab facility, as far as educating, training, and then making this whole process a little less stressful. And, there are strategies, and just with an increased understanding of dementia, the changes, how the brain's changing, why it's changing, what to anticipate, and then how we as caregivers of somebody with dementia, or as Teepa would have us say, care partners with someone who has dementia, just that increased knowledge base makes such a difference in the day-to-day interactions between the person living with dementia and the caregiver. So there are tricks, there are strategies, there are different ways of thinking about it. So I really started to explore that. And it was through the exploration that I learned of Teepa, who happens to be in my backyard, as far as proximity, not literally, but, just about a half an hour, 45 minutes away from me. And so I looked into pursuing her certification, because I also thought, what, this could be a future career path, a kind of a shift for me, rather than being in a rehab setting. The love and the passion that I was feeling for working with people with dementia and their caregivers, I thought, maybe I could branch out on my own and do something, use my OT hat in some ways, and then use a consultant hat in other ways, to be able to better the lives of these people who are being, touched by dementia. So I went through her certification process. as a consultant. And then I later took her trainer certification because the place that I work actually was inspired by what I had learned, and they wanted me to be able to bring some of that information to caregivers in the hospital setting, so professionals.
Brilliant. I absolutely love that. I love it. And it's so true. Do you know what? I loved what you said? Instead of the caregivers, care partners. And
Mhm.
right, I've heard her say that before. And it is actually, there's just something nicer about it, that we're in cohesion together. It's not a, it's not like the need to give. It's more like, hey, we're all collaborative.
Well,
Uh,
especially in the early stages of dementia, it really is more of a partnership because it's not necessarily that someone is caring for, it's they're caring with them, helping
yeah.
them to maintain a higher level of independence and peace around the changes and still be able to function as well as they can, without.
Exactly. No, exactly. And Heather, that's what so you said at the beginning of the stage of the dementia, yeah?
Mhm.
That's how we can help as well. It's the beginning stages. When if somebody calls me up, oh, my mother's, she's about to go into a home and she can't remember who I am, I can help them with their stress levels, and I can give them some kind of of how to guidance, if you like. However, I wouldn't be then working with the person living with dementia,
Mhm.
because they would be probably too far down their journey. It would more be working with the care partner.
Mhm. Right.
However, at that point, they are probably a caregiver. So that is so we as Lighthouse Brain Health Associates wouldn't come in at that point. I would probably ask you, or so I've got some other friends who come in and help with assisted living. So it would be more, that's what they would do. What we do, because we are hypnotists,
Mhm.
and Dr. Daniel Nightingale, he scientifically proved that hypnosis can help people living with dementia. Again, at the beginning stages, because what it can do is it can reduce the fear and the anxiety,
Mhm.
because we all know that when somebody has fear and anxiety, whether they've got cognitive issues or not, they're like that. And so, what the hypnosis can do with anybody, anyway, it
Mhm.
can help calm that down so that they are more clear minded. And
Right.
actually, maybe they can remember somebody's birthday. Maybe they can remember that, oh, they have a hair appointment. Because when the fear and the dementia gets so big in their head, because it's a very frightening word, and again, if it's whatever dementia it is, it
Right.
gets right stuck in the face. And then everything, well, I can't now. So then that becomes the new belief system. I can't. This is it. This is, my life's over. I'm at home. And you like me, we know it's a roller coaster of emotions. And so we help with that. We do a shared agreed action plan with the family, and we make the person who has this diagnosis the star of the show, and it's all about them. And we learn all about them, their hobbies, what they did, what they still might do, everything about them. So they're bringing the person back out, because it's about
Mhm.
building the personhood up. And then, well, what can we still do? What would we still like to do? What do we still want to learn?
Right.
So we give lots of brain health coaching. Again, I'm not a dietitian, okay? So I can't sort of like prescribe things like that, but this is what is advised, food wise. Oh, yes. And out of interest, how much, what do you eat? Oh, lots of sugar. Okay. Well, how
Right.
about we reduce that? Because, and tell them why, because sugar eats the brain. Let's get rid of soda. Yeah. Can we use stevia instead? What would that be like? How about giving it a go? Or can we just reduce it? And again, because there's things people can do. Oh, exercise. What do we like to do? Oh, you love gardening. Brilliant. So it's encouraging things like that. It's encouraging the walks. What would it be like if we did some light weights? And then it's encouraging the care partner to do this with them, because then if they're doing things like exercising their brain as well, sort of like learning new words, I don't know, what's our word for the day out of the dictionary? And there's all sorts of different things that we can do. Oh, let's have a go at getting dressed with our eyes closed, that sort of thing. Having fun games, making it fun. And because we know that there's neuroplasticity, and so it's about regaining those as I say, the brain, the brain
Neural pathways.
Thank you, the neural pathway. And so it's about doing that. Now the thing is that what happens with hypnosis is that they get a shot of acetylcholine, and I know you know what that is. It's one of our own good strengtheners for the neural pathways. And so when they're in hypnosis, because they're having REM, rapid eye movement, they're getting that. And imagine them doing self-hypnosis every day, or a recording that we might give them every day, because it would be about 20 minutes. Then they're getting all these shots of acetylcholine.
Interesting.
I know, isn't that wonderful? And then, of course, because they're relaxed, then they're calm, then they're clear-minded, and then they've been giving themselves positive affirmations only that they can do, or this is who I am, this is this is what I'm still like to do, reminding them every day. And then Tom Kitwood coined the word rementia, so it's regaining of cognitive abilities, because of you're regaining neural pathways, learning new ones. Yes, sadly, the dementia might be eating away at the other ones, but hey, as Norman Doidge said, if you're creating new ones as well, then that can only be a good thing. So that's what we do. We don't treat, we don't diagnose, we don't prescribe. We work alongside, say, somebody like you. We work alongside the doctors, the neurologist. We work alongside them. And it's like we would go in for a period of 6 weeks, and I go to the house. I do house calls because I need to check out the environment. And I don't know, because I'm very curious about this one, Heather. So I'm wondering what you think to this, because Dr. Daniel Nightingale always says that red is not a good color for somebody living with dementia, because it means fear. It's like the word stop. It's like danger. What's your take on that?
I think it really depends on the stage, like how far someone is in the dementia journey. But I can see where, yes, red would indicate that. But I think it's a very personal experience. I mean, if red's somebody's favorite color, they might be drawn to it. Because red is also about rules. When we're thinking about what the red stop sign means, it's about a rule. The red light is a rule. And you find as dementia progresses, rules don't matter anymore. It's because there's a cognitive component to that. But then there's also a semantic memory base for it as well, where you did learn that the red light means stop at a very, very young age. And so some of that is more of an automatic, habitual, ingrained kind of thing. So I don't know that I could give you a definitive answer on that, because I do think that color is a very, very, very personal thing. And I actually have someone I know who is a color analyst, color specialist. She actually works with people and their auras, and she talks about meaning behind color. But I even think that she would also say that, meaning behind color is very personal. My mother-in-law sees the color gray and blue, and she says she feels depressed. I see colors gray and blue. Well, gray not so much, but blue to me, it's my favorite color. I mean, it just everything about blue is happy to me. So
I don't like gray. I don't like gray. will very, very rarely see me wearing grey. I agree. But red, you see, red is my favourite colour. And I go to, so it's, you know, we were advised, say, to encourage people to get rid of any red. Well, I think red can be quite a jolly colour.
Right.
You know, red is great. We have berries that are red, Christmas, you know, and because I've got a client and he's often in red, and I just think, well, you know, so I never say anything because actually he chose it,
Right.
and so it's I just think, well, he's okay with it, so why would I bring that up,
Right.
you know,
I
because
think
that's yeah,
the big thing with color is that, there are changes in vision with the progression of dementia. And there are changes in the ability to perceive peripheral vision.
yeah,
And then eventually contrast, so higher, lower contrast items. So the color scheme of things with someone who's living with dementia, it's about, can they visually find things? And what does it trigger for them? Sometimes a change in color, and it doesn't necessarily matter what the color is. Example, oftentimes when we're worried about somebody leaving an area and they walk, their visual gaze and it starts to fall into a downward position. So the floor is used to help somebody to either navigate, or
mm-hmm,
sometimes, some cases, that can be the stopping. So when someone goes from one room to another and there's a transition in the type of flooring,
mm-hmm.
or like a sharp contrast in tile color, sometimes that will really stop somebody dead in their tracks, because the perception of that change might be that, oh, I'm going to fall, like going down the stairs. So they might stop for fear, trying to maintain some degree of safety. Of course, there's a point where safety goes out the window, but that actually is a strategy that can be used sometimes, is even to put a big thick piece of tape across an area because it's a place that someone shouldn't be venturing.
Yeah, so I've heard that it's like if they've got a Lewy body, especially, that's like the big, you know, big dark holes can be like a,
Mhm.
they think it is a hole, you know, and if they go to a supermarket and there's like lots of checkers, then that's like, can you imagine that, thinking that you can
Yeah,
only step on the white? I mean, we did that as children, you know, if you step playing
right.
that game, you know, if you step on the line or something, you know, the crocodiles will get you. So so it's the same for them. However, I also know that it can be used so that people, and again, so this is what we say, and I don't know if you TIPA does, or and you do, is that we discourage the word wandering. We
Mhm.
like to say walking with purpose. So we get curious, and where are you wanting to go to today? So that's to help more of the, when the person is a caregiver, really. Um, but that's why when a big black hole can be useful, so that they go, oh, I'm not going to go out through the door tonight, you know,
Right.
because there's a black hole there and I might get sucked in. So, you know, bells, I don't know, there's all sorts of things. And of course, ping pong balls in the toilet bowl for men.
For the color, yeah.
Yeah, for the color, colored ping pong balls, or a, you know, so that is why we go to people's houses. And of course, for the shadows, you'll know a lot more about uh you know, the stage when it's like, and it's often around the end of the day.
Yeah.
um so it's so what do you think to that? I mean, does that happen a lot in your
Very
experience?
common. Very common. Yeah. And a lot of times we see it as we see it because there's a reduction. Well, there are lots of different reasons. And again, part of the consulting process, and it's one of the things you learn when you go with TIPA, it sounds very in line with what you also do, is really it's about getting to know that person with dementia, that person and what their experiences are, what their routines are, their old habits, their current habits, preferences, all of that. Because for some reason, or for some people, it might be that they've been in their home and inactive for too long during the day. They've been sitting, they're sedentary. And then by afternoon, they've got all this energy that's wound up that they're really feeling like they need to get rid of that energy. So, a lack of exercise, lack of movement, lack of purpose throughout the day can feed into what it's oftentimes called sundowning, because it just seems
Yeah,
coincidentally to be at that time of day when the sun is changing. And, we're real sensitive to the changes in in where the sun is.
Yeah.
It's like kind of a primitive response to preparing for sleep. But they get more active rather than less active because perhaps they weren't busy enough during the day. It can also be because they were someone who was working every day, and it's now time where they're used to a normal transition. At this time, I'd be packing up my bags, I'd be getting ready to go home. And
Mhm.
so they start to get more active, looking for the going home feeling that they had before when they were, winding up their day at work. And so, that could be another reason for that. But there are lots of possibilities to it, but those are some of the more typical.
And and I can only, if that is for somebody, then there must be a way to help the person do that, feel as though, I mean, even if it's taking them on a little car journey with
Mhm.
a briefcase or whatever
Yeah,
they used to have.
yeah.
Um,
And it
and
can be sometimes reapproaching the house and no, it's time to be
now
home.
we're coming home,
Now we're going to make dinner. We're going to do all the things, but yeah.
so that's where it's a collaborative effect, as you say, working with the whole family, so that it's just a more reasonable experience, and it
Yeah.
doesn't need to be so scary and frightening. Now, something else that we do is we give say an anchor into something. We use a lot of NLP techniques, neuro-linguistic programming,
Okay.
and we find out something, say that they always used to like to say watch, or what's their song, what's something that they like to do. They always put a smile on their face. And so I had one client, and it was because he and his mother used to argue a lot.
Mhm.
And and he was saying to me, well, what do I do when she starts shouting at me and she starts telling me? And I said, and I asked her, I said, what can we do? Because they have all the answers.
Right.
And I said, so we she's a beautiful singer. Okay. She's got gospel singer. And I don't know how we got onto it, but anyway, we got to the song Zippity Doo Dah. And so we got to it, and I said, that's what you start singing, and then your mummy will start singing. And that's what they did. So that whenever there was anything that was going to get fraught,
Yeah.
whatever, because look, we're all human beings, we need to understand that there will be tension. It doesn't make them a bad person. And that's what we're there for as well. We're not judgmental, we're not, it's there. I get it. It's like, I get it, it's hard, it's
Yeah.
it's horrible,
That
because
sounds like a great strategy that you're using, because that is another thing, is really just trying to figure out what, we look at triggers, and we look at things that are strong preferences, things that create joy, cause joy. And music is actually one of those things that is preserved for the longest amount of time. The ability
yeah,
to recall musical verses, prayer, poetry,
yeah.
counting. Those are things that someone can maintain for a very, very long time. And so we can use those as strategies.
So that's so that's what we do. And then I because it's very close to my heart to help people get rid of any traumas,
Mhm,
significant emotional events,
mhm,
because again, you like me know that if somebody's down their journey a long way,
mhm.
and they are now in a home facility, and say if they have been abused, and somebody comes in and is going to wash them, and say that person doesn't actually say, hello, my name is, and is it okay if I wash you now? I've got lots of towels, and we're going to start with your face first and your hands, and then and I'll tell you as we move down the body. Is that okay if I do that now? And some people don't do that.
Oh, most people don't do that.
Right. They go in, will just get their hopefully warm flannels, washcloths. But just imagine if somebody if right now, and say we don't even have a cognitive disability, somebody pulls my bedding off, gets a washcloth, I don't know who they are, and they start washing my bottom.
Right.
Well, I think I might hit them.
Right.
Okay. So imagine if you have been abused,
right.
or if you're you're an ex-military, and somebody just comes in without you knowing. Well, actually, yeah, like I said, I had to hit them. That's called aggression. Oh dear. Then you are strapped down.
Mm-hmm.
Literally, they call the other people in, the security people. Oh, then now you're on psych meds because you're dangerous.
Right.
Right. Now you're probably dead in about a month because you're on psych meds. Because you're probably so gaga, you can't eat, you can't drink, and that's it. So I would really like to do something about that. And I can. When somebody first gets their diagnoses, we know that they're still pretty cognitive. Yeah. And then because I do trauma work, and lots of my colleagues do, and I'm a certified havening practitioner, which is touch, but the person can do it on themselves. I have actually been doing this on my clients. I became an ordained minister so that I could touch people. Okay. And obviously I asked their permission, and their loved one is there as well. And I'm touching their arms, I'm touching their hands, and I'm touching their face. And what that does, it actually produces our own oxytocin and serotonin in our own bodies. And then it also oscillates the GABA waves inside the brain. So it pops off the negative stuff so that they're not going to forget necessarily what happened to them, but they might as they go into cognitive decline. But what it means is that it's no longer attached to their amygdala. Because we know that if somebody is in, say, a dementia, their amygdala is more on fight, flight, freeze. And if we've been able to, let me just get my little ball here. So say this represents your amygdala, and it's always looking after us, fight, flight, freeze, fight, flight, freeze. And when they're in distress, so I am able to pop that horrible thing that happened off. So say like it's a big blob of poo, I can pop that off. And I mean, it's called an AMPA receptor, but it's like, so that instead of going like that, they're going, I don't like this, because nobody's going to like it being washed like that, but they're not actually going like that and really screaming and shouting. I did this for a gentleman who was getting very angry with his wife, like really nasty, to the point she's absolute tears. And they called me in because she just said, I'm at the end of my road, been married for 60 years. I just can't do this. He's so nasty when he's angry. And it was interesting because I'm English. I used the word lovely about something. And he said, I hate that word, lovely. All right. Reminds me of my mother and my sister. I said, okay, tell me more. Didn't like his mum, didn't like his sister. They were so critical and have been so mean and awful to his wife during the years. And anyway, there was a lot of just didn't like her. She wasn't a very nice person. And I thought, okay, this is interesting. So we use our intuition. And because he might be doing something a little bit different, putting things, his wife is now saying, why did you do that? Now he's going, oh, you're so what? And he's getting angry. I'm thinking, So I did havening on his dislike, the feeling that he got around his mum and his sister. So that when his wife, and I've also invited her to get rid of the word why, because why often makes people second guess themselves. Of course, he's second guessing himself already. So she also, I found out, was finger wagging. I,
Oh,
I said, that's going to go because she can, because she's cognitive. And so, anyway, it's got a lot better. Let's put it that way.
yeah.
Because he's now not going there nearly as much. I mean, they're almost like just absolutely fine. You know, it's like he very rarely, or if he does, we've given another buzzword that they can use that
Mhm.
reminds them that that's not, you know, and it's like I've got yellow sticky notes, be kind on the fridge because they see the color yellow. And it's, you know, so that's where we come in and we get curious and we find out what's going on. But I love, but that's I think my mission more
Mhm.
so is to get rid of the traumas because I can, and so that people can go down their journey without them.
Yeah, I am curious. I think that sounds phenomenal. I am curious when you said that you would do the havening around, in that situation, his trauma with his mother. How do you isolate that trauma to do the havening? Like, do you recreate that stressful experience
Yeah,
through the
but
use of words? You trigger him and then you touch him as you're triggering him?
yeah, I asked him to think about it. Remember, you know, when you were so, and they can, because you know, they don't, people don't, when they when they've got dementia, they don't
Yeah.
forget. It's more the immediate thing that they've forgotten, like what they're doing tomorrow, that they've going for lunch later on, you know, or whatever, they're going to make a phone call. That's what they're more losing.
Right.
It's not the past. So they
Right.
remember vividly the past, say, of being hit or whatever it was, locked in a room or not being allowed. They remember that. So yeah,
Okay.
you have to activate them into it.
Hmm.
However, they're not in that for very long.
Okay. And then it's like the contrasting of the having this negative moment and experience and then providing more of a loving, nurturing touch to replace those feelings.
It's distraction, yeah. And then
Okay.
there's eye movements and there's all sorts of other stuff. But
Hmm.
that's my that's my mission around this, is to help
Okay.
people do that, because the other stuff is you know, people can read about it, you know, well, what do you
Right.
do? Yes, brain health coaching, yes, you know, you can and however, it's for me, it's getting rid of the traumas, um and for the caregiver, the
Mm-hmm.
care partner, because
Sure.
actually, and the children, if they are now going to have to look after their parent who actually they really dislike, then I've got
Yep.
to get rid of the traumas so that they can, or I can't get rid of them because I'm not magic. What I can do is help people be indifferent towards them, so that it's like, yeah, they probably were doing the best they could and they didn't know. Or again, frustration if there's, like, I don't know, any alcohol involved. There's a lot of alcoholic dementia.
Oh,
Uh,
yeah.
yeah, and it's and that's really hard to diagnose, I think, for people, you know. But alcohol will eat your brain. Too
Mhm.
much of it, it will, and soda, and I mean, I'm sure you've heard, I don't know who actually coined it, but that diabetes is like the third dementia.
Yeah, I've heard something about that. Or they're calling dementia, somebody is calling dementia diabetes type 3,
Yeah.
which I have not done a lot of research on, primarily for me because I'm not into I mean, I'm aware of, and it's important to understand which type of dementia somebody has for the
Mm.
presentation of symptoms. But I also, like you, I do not diagnose, and I'm not treating the dementia per se. But I work with the families and the person with dementia. Again, it's a considerable amount of overlap to what you do, but without the obviously the havening or the hypnosis. Um, but a lot of it's really about teaching and training the care partner in how to interact with the person living with dementia to optimize their independence, their comfort, again, for the amygdala firing, to reduce those stressful moments. If we can anticipate what someone's unmet needs are, what kinds of things are triggering them, how to create more of those positive moments, we can have more successful experiences throughout the day. And then the OT part of me wants to look, like you were even saying about all the function, really looking at not just creating simple meaningful activities, but really like, how can we help you to thrive? Like, what are some of the things that really create joy for you, and let's get you experiencing those to the best of your ability, um,
Yeah, I
instead
know.
of just existing.
Yeah, so that they're not just existing, they are living.
Right.
So I've got this one couple, it's so wonderful. They go to, he does Rotary, his daughter takes him along, and it's just it's good,
Mhm.
so that's nice. I've got this other family, and I love it. She's brilliant at puzzles, and so that's what she sits and does all day, and she loves coloring. So that's what she sits and does all day. And it was funny because we do the an assessment, the MOCA test, just to give us a
Mhm.
baseline. And then we
Mhm.
see in week 4 that we see somebody in week 6 how they've improved. And there is generally a regaining of cognitive abilities. But this one lady, okay, so she's 87. And I asked her, what year is it? And she's going, oh, 1980. I'm going, so, well, if it's 1980 to her, now she was an athlete. Okay.
Mhm.
I mean, she used to yacht, she used to play tennis, she did golf. She was, well, if it's 1980 to her, she can still do all those things.
Right.
And do you know what? She does. So she lives with her son. He set up they've got, a bit of land, and he set up a putting green for her. He's got a tennis court. So
That's great.
and he plays tennis with her because she can. According to her, she can. And I said, get a hoop, and I said, get some a basketball. Not a high one, but it's just fun to play hoop.
Right.
Yeah,
Right.
it always is. It has been. So it's like, yeah. And then of course that's a weight. You see. So it's like, and he's just got them another puppy as well. So it's like, so I mean, she's living in her own la la land, but it's old age dementia. But she's as fit as a fiddle.
And she's happy, and when she's happy and feels like she's thriving and has purpose, then
Yeah,
everything's going to go much more smoothly for everybody.
yeah. And it's just like, yeah, but she hasn't got a clue who and lots of things are, or what. It's
Mhm.
actually probably quite so it's and it is, but it's about putting a smile on people's faces, and bringing joy back. And that is what I always encourage with my clients, is that reminding them they actually are the co-regulator.
Mhm.
So their mood, that's why we have to help them, and that's why the hypnosis can help them. And just knowing that they can call me if there's something going on, because because again, if you've got the son or the daughter or whoever it is who's, say, in their mind having to look after because
Mhm.
they can't afford the 5,000 a week in the care facility, and they're not even that good at 5,000 a week.
Oh yeah, right. Right.
I have been shocked. It's so sad. And so they're having, say, because they've got this trauma. So if I can help them release that so that they're indifferent to it, get from having to getting to.
Right. Right.
Because it's a duty, but because it actually in turn will hopefully give them the warm fuzzy feelings that they are actually being compassionate and empathic and helping another fellow human being who, unfortunately, yeah, may have done this or that to them when they were younger.
Right.
Because if it can only make the whole atmosphere for everybody awful if the if the person who is cognitive, the co-regulator, is as grumpy as anything.
Oh, for sure. For sure. So
So
how do you deliver, like, what is your beginning, like when you're first getting to know somebody, and a determination to what you mentioned that you kind of set up a care plan. I don't
yeah,
think the word you used, but you said something. So what
shared
is,
agreed action plan.
okay.
So together, the person living with they've got its new diagnoses
Mhm.
together, what so we fight. First of all, pretty much the first hour is all about them, tell me about you and this. And then it's are you okay if I do this quick assessment? So then do the mocha assessment. They've had it many times before, so sometimes some people are really good at it.
Mhm.
Drawing the clock, because there is a knack to drawing the clock.
Sure.
But and then it's like, okay, that's great, now we've got a baseline, and I'm saying I'm not diagnosing, just a baseline of where we're at, so that we've got something that we can see the progress. And so tell me more about food. Okay, so then it's about the food, and then we're inviting them. This, you might like to try this, maybe turmeric, blueberries. You can have dark
Mhm.
chocolate instead of lots of a whole pack of Hershey's, all that stuff. Okay. But turmeric is known to be very good. Coconut oil, I'm on the, because that can cause diarrhea. So that's got to be introduced very in little bits in a coffee, because people won't know that they're actually having it, but just a very tiny amount. And they wouldn't even notice the taste. But if they're going to do, say, stir frying, use coconut oil, avocado oil. Again, just
Mhm.
noticing.
Mhm.
And then and is this okay? Because if the person, if the whole family is eating more fish,
Mhm.
omega-3, then that's good for the care partner. Okay, because we often know that it's the caregiver that can get issues as well.
Sure.
So it's because they're exhausted, can be exhausted, or they feel as though that's suddenly their life, they're going to be exhausted. Then it's the brain health coaching techniques. So every day giving them something new to do. And what do they like to do? Well, what are their interests? Well, what did you always want to be interested in?
Mhm.
Because
Mhm.
they may know a lot about birds. Would you know a lot about dinosaurs? Would you like to know about dinosaurs? Would you like
Mhm.
to know about cooking recipes? Would you like to know about this? Would you like to know that? So something that they would like to learn but never did. Because
Okay.
if they already know it, well, then those brain synapses have already been built. Okay,
Sure.
let's learn something new. A new word every day from the dictionary. I mean, that can be quite good fun. Okay. And then of course I always say, oh, do you remember when we were younger? Because you generally older than me. I mean, I remember looking at naughty words in the dictionary, because what's sex, and then of course they're laughing, so
Mhm.
it's that kind of thing. So I'm always making it fun. And so then again, exercise. What do you do? Can we go for a walk every
Mhm.
day? 20 minutes walk. As I say, just what can we do? Because again, it's maybe they're immobile. Okay, so what can they do?
Right.
So chair exercises. It's that sort of thing. And then about outings, that sort of thing.
Sure.
Friends, let's what's just what else. And so you set that in place, and then I teach them self-hypnosis.
Okay.
And I generally do, and I don't necessarily call it even hypnosis, because I've had to sign an affidavit. I got in trouble from the psychology board saying I was doing hypnosis on people living with dementia.
Right. Who
You know
might
what?
not be competent to decide their, was it about that? Like,
Yeah, well, I can do guided meditation.
okay.
Okay.
Yep.
Because and I actually told a neurologist about this, and he said, "Oh, how ridiculous!" And he goes, "I absolutely love that you are doing this, because if they're getting acetylcholine through that, then they're going to need less drugs. Then they're going to need less drugs for the drugs. Then they're going
Right, right, right,
to
right.
yeah, because they'll have a I don't know, whatever it is that they're on, and then but that causes high blood pressure. Oh, now they need a thing for high blood pressure. Now they need a thing for constipation. Now they need a thing for, oh, for goodness sake. It's like,
Yeah.
so less drugs, he says, can only be a good thing. So I love that it's all natural. And of course, we all go into hypnosis every day anyway, because when you're driving somewhere and
Oh, yeah.
and you're going home, you suddenly go, "Oh, why did I get home?" You were in highway hypnosis, okay?
Yeah.
Probably an alpha, which is, and it's all a natural state, and I explain this because a lot of people have played sport, and so they go, "Oh yeah, I remember getting into the zone." Well, you were in sport hypnosis, the zone sport, because you didn't go, "Hey, mum, hey," because the moment you
Right.
did, you got hit in the head by the ball. So it's like, so everybody goes into hypnosis all the time, and so I make it fun, but I don't do a full-blown hypnosis session or
Okay.
guided meditation in the first session, but I personally do like a mindfulness one, which is like 5 minutes,
Sure.
and they go, "Oh, I really like that," and I will record it and I will give it to the person, and then they get to have their partner, and then they have that, and then they can all do it. It's like 5 minutes, and oh, this is nice.
Oh,
And
good.
then next time I go, and we just chat. What else? What else? Check in how the shared agreed action plan is going. What
Mhm.
else? And then we'll start doing some hypnosis. And so yeah, that's and
So do you change their hypnosis plan? I mean, as far as once you've established this with them, you've done your initial sort of assessment, you've created your plan, you've given them the hypnosis, the self-hypnosis. What's the frequency for how they would check back in with you,
I do
or
it
like
once a week.
once a week?
I do it once a week for 6 weeks, and
Okay.
I aim to make it the same day, the same time,
Okay.
because that makes sense.
Yep.
Sometimes they might be going on a trip. Sometimes they have a hospital appointment.
Right.
Sometimes they've been ill, so we just do it the next week, and
Okay.
then you come in. It's about being flexible.
Oh, yeah. And
Um,
you're always in person for these appointments, or do you ever do a
I
virtual?
have done it virtual. I have done it virtual,
Okay.
and I did it with a couple, and actually he was in decline as well from alcohol. She was definitely in decline from alcohol, and it was she actually just didn't want to do it. She didn't
Mhm.
like it. She didn't want to do it, and she was like, he did, and he did it for him, but it was she was just sat there crying a lot. We got a bit better, but it was she I think when it's the alcoholic one, it's just
It's a tough one. It's a really tough one.
yeah, and I had another couple I went to, and that was an alcoholic one, but she was already on so many psych meds, um, and they couldn't afford not to do anything. He couldn't, so he just anyway, she died. But when I did the evaluation, she scored 0 out of 30.
Oh, wow.
I mean,
Yeah.
it was, and I would, and the children were paying for me to go. And I actually went for him once, just, and it was more, and while she was there, I'd do her nails. You
Yeah.
know, I'd
So
yeah,
do
and
you,
massage
oh, I'm
her
sorry.
hands. No, I'd just massage her hands and things,
Yeah.
and it was
Yeah.
more for him.
Okay. Do you generally, if you have, a person living with dementia and a care partner, who do you determine as your client? Is it always the care partner, or because if you're also providing the meditation practices, or hypnosis, as we shouldn't call them, or whatever, um, do you how do you determine who your client is? Or would your client be your person, like if it's a daughter who's paying for you to go in to work with her parents? How do you navigate that?
That's a really good question. So I get a lot of signatures, and it's so if the if the care partner wants to work with me separately on some stuff, then they're obviously, because they're cognizant, they are my client.
Mhm.
The person living with dementia is my client.
Okay.
And I have to always remind that to some people, because I've got I love them to bits, but she talks a lot,
Mhm.
and it and I have to really bring it back to him all the time, because he is my
Mhm.
client. He is my client, not her.
Right.
And yet she often, because she just loves to talk, it becomes about her, and I have to go, I really have to bring it all the time. So that can be, sort of like hard work. And even once he actually said to her, what's the point of Claudia coming? Because all you do is talk to her, and you don't let me talk to her at all. And she told me that, and I said, okay. I said, well, we'll really make sure. And but she still does it. She's like, she just can't help it. She's a talker, but it just made me even more cognizant about bringing it
Who
back
the
to
client is, sure.
and and what do you think? um it's but yeah, it's I say, and I've sort of like called her up, if you want to see me, you come and see me, because
Right.
she can drive
Right.
to me.
Okay.
So, and I have done that. We've done that a few times, where she's literally just, I'm not an American therapist. I'm not a counselor, but that's what she needs to do.
Sure.
Um, and it's like, and that's what she uses me for. Plus, I will get rid of some of the traumas. I'll do havening on her.
Oh,
So,
heck yeah.
because I
Sure.
can and I know how. So yeah,
Right.
we do what we can, and it's I love it, because the family, after the 6 weeks, I will then generally go back every month. They keep me
Okay.
once a month, just to check in, just
Okay.
because I've given them the recordings, and I just go, are you doing them? Are you doing them? And so then, yes, you ask that question, well, do I change the recording out? Yes,
Right.
I do, if there's something different come up, because
Okay.
I work with, I don't work off scripts. I work with, because I've got all the scripts are in my head, so I do, because they're in my head.
Yeah.
But it's I work with what they might need to work on, and I invite them to do their own work, because they may be on a beach, and there may be a conch shell appear, and they hold the conch shell up to everybody knows what a conch shell looks like, while they're still in this, because as I say, I don't see people too far down the line, when I don't go to the homes, and hear what does it say? What's the
Right.
message? And there may be a bottle, because we all have that, that curious thing of message in a bottle, we all remember that. um
Right.
Youngsters might not, but my age and older do. um and so there's a message. What do the magic words say? Just notice what they say, and it's the message they need to hear.
Mhm. Mhm.
uh and or again, it's like, and I always invite them to bring back a good feeling. What was a time when you felt really good about yourself? And we anchor anchor the good feelings in,
Sure.
and then hold on to that wonderful feeling when you were feeling confident, when you were proud of yourself, when you could do all those things, and then they bring that feeling back.
Yeah. Yeah.
So it is nice. So it works together with what you're doing. So yeah.
It does. It sounds like there's a really great complement to each other in those two practices. You do a little bit of what I do
And I
with,
don't do occupational therapy.
well, and I currently am not providing occupational therapy services, at least not unless someone has fully exhausted all of their occupational, like their Med B benefits, because I'm not, the way I deliver my practice is not something that Medicare would reimburse for. And I would have to really change how I delivered care if I was going to bill Medicare. So, I have that OT background, the OT knowledge, the understanding, but I'm not providing services in a traditional OT model when I'm in my business. I am doing it when I'm in a facility, but within my business, I'm not doing that. So, um,
Tell me, how does your session, or how do you work?
my sessions generally, we start out with the initial, like I do a 30-minute consultation, a free consultation, just to really let them know what I do, what I have to offer. I don't ever want someone signing up for my services if they don't feel that what I have to offer is going to be beneficial to them. And then my initial conversation with them, it really depends on what they identify as their needs. If it's somebody who is looking for somebody to help guide them through trying to discover long-term placements or assisted living, that one's going to look very different. But there's a lot more dialoguing, but there are definitely elements. If it's really about keeping the person living with dementia in their home, it is going to be, I send them, I've got kind of a intake form that really goes through a lot of the questions that you guys discuss, as far as what are the preferences, what are the habits, what are the routines, what are old triggers, what are current functional levels, like what is this person able to do, what are they not able to do, and then also checking in to see what the caregiver, care partner, what their burden level feels like, where are they on a stress scale, so that we can really get a good feel for, are they feeling extremely stressed, or is it just that they want a little bit of help in there? And so it's just trying to get a big picture of what are the goals and the wishes of the family. And sometimes people come to me and it's just they have one issue that they want to work on and they want to address. And so we can spend a consulting session really just teasing away that one thing. It might just be about feeding, it might be about toileting, it might be about sundowning. And so it's a little different in that I'm not, I like your model where you're giving, you have these kind of strategies that you're trying to implement with the exercise, the changes of the diet, things like that. I think all that is fantastic. Mine is a little bit of a different shift in that we try to tackle a challenge each time they reach out. So it's not necessarily me telling them what to do, that these are the things you need to change. They tell me what is the problem, what's not working, what feels stressful for them. And then we tease it apart using all the information that we've gathered from that initial session and that intake about who that person is, but then also really looking at each individual circumstance and educating them in real time about, okay, this is the type of dementia, this is what these are some of the brain changes that are probably occurring. So how could we, and then it's like asking them, how do you think you could adjust to this? And of course, I've got ideas, lots of ideas in the back of my mind, but my goal is to educate them in a way and to ask them all the right questions that they can start thinking about it for themselves. So
Brilliant.
they don't need me to be their person every time there's a problem. Oh God, what am I going to do? I need to call Heather. I want
Okay.
them to think, okay, how did Heather teach me to think about this situation, so that they become more confident in their
Yeah.
own ability to solution those day-to-day challenges.
Yeah. Brilliant.
It's a little different in that regard.
Yeah.
It's not counseling. It's not, I also offer an element of training, which is like a training them on how to do physical, as Teepa calls it, a positive physical approach. But you described it in what you were saying to me about the bathing, right? It's training them in physical ways of approaching. Where are you standing positionally? How are you holding the person? How are you just using verbal? Are you using visual? Are you using tactile cues? Like, what are all the things you're using, and how are you using them to also enhance the delivery of assistance?
Yeah,
So
exactly. Because it's the tone of voice, it's the body language, it's
yeah,
It's
It's the rate,
every
and when you understand the brain change and you understand where they are in the stage of brain change, you also learn about how the speed of your speech can impact the delivery, the content that you're using, the quality of words, the pauses that you may or may not be taking to allow for the processing time. So there's a lot of the science behind the declining brain, the areas of the brain, the um in that. And so I
singing is so good.
exactly
Sing it,
exactly
sing it, because it will make you feel better as well. You know, let's get the bath poured now. Let's
yes.
go out for ice cream. You know, it's just like whatever it is, because it's in the Brox and Vernix bit. And if they can't, have you ever found that? So I have got a couple of friends, and they've not done it. I've said that her husband's got dysphasia. Am I saying that right? Dysphasia?
Aphasia, dysphasia,
Aphasia.
swallowing,
Aphasia.
aphasia,
Aphasia.
communication.
He can't he's not can't get his words out. And I said, sing to him, see if he'll sing back. And she
Mhm.
won't do it. And I'm like,
Oh.
and I want to know. So have you done that? Have you actually done that with anybody who's got aphasia? And said,
Well, yes, I actually, there's somebody, I don't want to identify her, but there's somebody that I know very well who she does not actually have a dementia, but she does have a true expressive aphasia from a stroke. And
okay,
she's unable to have a conversation. You can ask her questions and she has one word responses, but they're generally the same one word response. And so you learn from her tone of voice whether she's saying that word meaning a good thing or that word meaning a bad thing.
okay,
Kind of like amen. It'd be like a amen versus
yeah.
a amen. Like that, yes versus no, right? But this person can sing any Bible hymn, any Christmas carol. And that's what she does. She can sing the entire thing from start to finish, not missing a word, but she cannot do spontaneous, regular back and forth dialoguing with anybody.
And could she do dialoguing in sing song?
She, I have not tried that with her. I don't believe that she can, but I do know that some people have, yes, because it does, especially if you're trying to have them sing something that is a familiar tune to them, not making up, not just doing sing song necessarily, like where you're creating your own music, but if you were to set something to like this old man, he plays one, but if you were like you use the name of the person, the task that you were trying to do, you created it kind of a repetitive thing, they might join along and sing the words with you because the
Okay.
tune triggers
Yes, but remember the tune.
them.
Yeah, row, row,
Yeah,
row your boat, or yeah, okay.
right.
Old MacDonald, all the real
Like
repetitive.
nursery rhymes kind of things.
Yeah,
Yeah.
yeah, yeah,
Yeah.
yeah. Oh, I'm sure. Oh no, okay, okay. I like that. And it's about getting curious. It's
Hmm.
about playing with what does work. Okay, that didn't work. That's fine. Let it go.
Very much.
What
Yeah,
else can
very
we do?
much.
What else can we do? What else can we do?
Yeah.
So that's what we always invite people to do, is to always get curious. If there's a poor behavior going on, it doesn't
Yep.
mean, or it could mean a UTI, for instance.
Exactly.
Get the water. So we
Yep.
always encourage that. It's about, again, giving them tools, techniques, strategies, getting curious, and making sure that you leave them with a smile on their face.
Absolutely.
And that's what I do when I work with people. Like I said, I go to the house and I give time. I'm 2 hours. I'm there for 2 hours.
Okay. Yeah, that's great.
It's like, and I become part of the family. I give them a Christmas gift. I get Christmas gift.
Cute. How do you get your, I actually wanted to say too, though, I do have another meeting coming up,
Sorry, you
so
better
we'll
go.
have to
Okay.
wrap it, but that's okay. I was curious. I wanted to ask you too, how do you get your referrals? Is it word of mouth? Do you go through doctors? What is your process?
Word of mouth, because people just know that I can help. Yeah.
Sure.
because I have to be quite careful about advertising it too much, because the psychology board just tell
Sure.
me off. And because I do this other thing where I work with children, I've created this thing, the bunny talk process.
I did see that.
Yeah,
Yes.
which is an anchor again. And I've told my daughter, if I ever get dementia, will you talk to me with the bunnies? I may
Yes.
forget you, but I'll never forget the feeling, because it's about the feeling, isn't it, that we
Uh-huh.
get from people, the feeling of the bunnies. So she'll do her daughter bunny, and I suppose I'll still have my mummy bunny. And so I've asked her to do that. My main thing for me is I'm all about helping people with trauma, with
Mhm.
but I'm not allowed to use that word. So significant emotional events, the bad significant.
Sure.
We don't want to get rid of good significant emotional events, but the unfortunate ones. So
Right. Right.
that's my jam,
All
so
right.
and I can come in and out. So if you are working with people but they've got this, then I can just come in, do that, and then they're yours again. So
Right.
really that's what that's about.
Okay. Yeah,
That's
that's
how I can
great.
help. And I'm relatively I don't know how much you are. I'm $347 now a session. So it's like that can, I mean, obviously I then might do a pack with people,
Sure.
but I'm still relatively expensive for my time. I don't know how much you are.
I am newer, so I'm not as expensive. My initial consultation, because I do a write-up, I do some out of the session, but I'm a 60-minute session, and I believe I'm 150 I think I'm 150 for my initial, and then my regular sessions are 125 for an hour. So
Okay,
it's
so
definitely more
hours. Yeah. So, but I'll and some of my clients, they're still at my 250 rate, because they were when I was,
sure.
way back when. So they are. But if if I see that they say, oh, it's too much, I will be referring you.
Okay,
Okay.
that's wonderful.
And
And
then
likewise.
yeah, and just literally, but I would just come in and troubleshoot a trauma.
Okay, that's
Maybe,
perfect. And
and
then
then you.
I would take over with the day-to-day challenges and
Yeah.
making life look smoother.
Yeah, or the caregiver, if they don't like who they've got to look after, I can help get rid of
Definitely will let you
that.
know.
Okay, so that's where we can collaborate.
Sounds
Okay,
perfect. Yeah.
so
Thanks,
all right,
Claudia.
so take care. All right, look
All right.
after yourself. I'll see you soon. All right,
All
bye.
right.
Hannah. Bye.
Bye.